Welcome everyone to today's webinar. My name is Emily Rapley and I'm a managing editor with Becker's Hospital Review. Today's webinar will begin with a presentation and a panel discussion. We will have time at the end of the hour for a question and answer session. You may submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to answering your questions. Additionally, in about 1 week, we will send you a copy of the presentation. This will be sent to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our panelists. Jordana Davis is the president of Rockingstone Group, a healthcare consulting firm in New York. She launched Rockingstone after 7 years at the Sachs Policy Group, where she consulted New York's largest hospitals and health systems, helping them adapt to the rapidly changing regulatory and market dynamics in the healthcare system. Before her consulting work, Ms. Davis spent 4 years on Capitol Hill, first in the office of Senator Russ Feingold, working to draft the State-Based Healthcare Reform Act, and later serving as a senior healthcare advisor to Senator Sheldon Whitehouse during the drafting of the Affordable Care Act. She also drafted legislation on health information technology, healthcare quality improvement, reimbursement reform, and graduate medical education. Ms. Davis received her Bachelor of Arts cum laude from Yale University and her Master of Public Policy from Georgetown University. Christy Murfitt is Vice President of Product Marketing at Imprivata, where she is responsible for developing and driving the global execution of the go-to-market strategy for Imprivata's solutions. Specializing in the healthcare IT market, she moved into the high-tech speech recognition software industry in its early years, spanning solutions for customer service, mobile lifestyles, and health IT. Ms. Murfitt has a Master of Science in Marketing from the University of Leicester and a Bachelor of Arts in International Relations and Anthropology from Tufts University. She is a member of the Phi Beta Kappa Society. I'm pleased to turn the floor over to Jordana to begin today's presentation.
Thank you so much, Emily. Welcome, everyone. Good afternoon. Thanks for joining us. Today we're going to start talking about MACRA. MACRA is the Medicare Access and Chip Reauthorization Act of 2015. Then we're going to talk about MACRA's relationship to our topic of the day, patient identification. We're going to move on to the repercussions of misidentification when that happens. And then I'm going to turn it over to Christy, and she's going to talk about creating a one-to-one link for patients and their records, as well as ensuring continuous data integrity. We get the next slide. And the next one as well. Thank you. So MACRA was actually, as hard as it may be to believe in this day and age, a bipartisan piece of legislation that passed in 2015. It passed almost unanimously. Again, something that's a little bit hard for us to remember in this day and age. And there's really two reasons for that. One of them is a really nerdy reason, and we won't go into the details of it, but it's that before MACRA, Medicare payment was mired in something called the sustainable growth rate. And it was a paradigm of payment that created a headache for legislators. Every single year almost it would come back, they would have to fix it, there was lobbying, it was a mess. And I think there's probably nothing like, headaches and annoyance for legislators to help them come together in a bipartisan way. The second reason was that we have a major problem in healthcare, and I think anybody who's a patient can probably just feel it from a real personal level, which is that we continue to pay providers on a volume-based paradigm. We don't pay them, for the most part, on a value-based reimbursement system. So every time a patient goes to the doctor or goes to the hospital bills for the service and they're paid in what we call a fee-for-service way. And they're not necessarily paid in any way that's related to the quality of the service they deliver, how well they coordinate care between the doctor you're seeing and all the other doctors, how well you discharge potentially from your inpatient stay to a post-acute provider, how well they coordinate the medications you're on. All of these things that we know lead to really good care, our payment model simply doesn't promote. So MACRA was an attempt to really change this, to move from a volume-based reimbursement system to a value-based reimbursement system. It's not new. It's a market trend that's been going on for a long time, but it did really need to be changed in the Medicare program. This is a really, really broad bill, though. It's going to affect 600,000 or more clinicians. and it's going to push clinicians into one of two payment tracks. We can move on to the next slide to talk about those. The two tracks, one is called MIPS and one is called the APM. So MIPS is where most providers will find themselves. It's called the Merit-Based Incentive Payment System. And it will essentially take the regular payment that a physician is used to seeing, but instead of just blindly making that payment, it's going to try to adjust that payment for some of the things we just talked about. For quality, how good was the care that the patient got? For the resource use, were you sort of careful as a provider about the resources you used to get a certain outcome, or did you do lots of testing, or were you thoughtful about it? It's going to measure your clinical practice improvement, and it's going to measure your use of important tools like an electronic health record. But this is going to be just keeping the financial pie the same. So if you're a physician that does really well on a lot of these measures, you're going to get a bonus. And if you're a physician that does really poorly on a lot of these measures, you're going to get a cut. And if you're somewhere in between, you'll get nothing. Some providers will have a neutral adjustment. So this is not going to cost the federal government more than it would have otherwise. The estimate is that about 43 to 47% of clinicians will qualify for this payment pathway in the first year of the MIPS program. Then there's something called the Advanced Alternative Payment Model. This is for providers who are delivering care at a more sophisticated level. They're taking a more sophisticated approach to care. Many of you may have heard of something called accountable care organizations. This is the kind of thing we're talking about. So here we're talking about maybe providers who are together in an organized group, maybe as a health system, maybe as a doctor's group, and they have an arrangement with CMS where they say, we are responsible for these, say, 5, 10, 20,000 patients, and we're going to care for them in a more sophisticated way. We're going to care for them across the continuum. We're going to provide all of the care that they need, and we're going to be measured not only on the quality of what we do, but on the cost of what we do. And we're actually going to have some skin in the game financially for how well we do on the care of those patients and the value we deliver. Physicians that fall into this profile are exempt from the MIPS profile we talk about on the other side. We think only 1 or 2% of clinicians are going to qualify for this payment pathway in the first year. And we actually think that more than half of clinicians, so 53 to 57%, will probably be exempt from both pathways in the first year, simply by not having seen a sufficient number of Medicare patients to qualify. The timeline on this is fairly aggressive. Providers have their data due to CMS in March of 2018, and the payments will begin to be adjusted by January 1st, 2019. And providers that do not submit data at all will actually be cut 4%. So it's a very significant penalty. There's two sort of important side notes not on this slide that I just want to go through. One is that in June of this year, CMS put out a proposed rule. And a proposed rule just makes some slight modifications to the major piece of legislation. And it's important because the proposed rule talks about more flexibility, easing requirements, extending timelines. And so we think when that gets finalized, those are probably the types of changes that we'll see. The second thing that's important is there's a body out there called MedPAC, the Medicare Payment Advisory Commission. It's a group of academics, of providers, of government officials who get together on a regular basis and make very important recommendations about the way the Medicare program should be run. They have no regulatory authority, they have no legislative authority, but their recommendations very often have a significant impact on both regulatory and legislative activity. And in early October of this year, just a couple of weeks ago, MedPAC came out to say that they're pushing for the repeal and replacement of MIPS. They think it's burdensome, they think it won't improve care, they think that the measures that the doctors have to report on are really just about their own actions and not true patient outcomes. They think clinicians actually choose their own measures and it's not going to be really accurate, it's just self-reporting. So we will see some draft recommendations on this in December. They will put out a report in March, and we may see some really interesting comments on MIPS for those of you who are paying close attention to this, as many providers are. Okay, next slide. So there were 600,000 providers that are going to be affected by MACRA. That's a huge number. We think of that and it's really impressive in its scope. And yet, a provision in MACRA that has gotten much less attention will affect many, many more Americans. And this is the new Medicare card initiative. So since the inception of the Medicare program in 1965, CMS, of course not then called CMS, but now called CMS, included Social Security numbers on the cards. And if you are like, you know, any of the many Medicare beneficiaries I know, even those in my family, this has always brought great fear and concern. Why is my Social Security number on my card? I know people in my family who have actually, on recommendation of their physician, made photocopies of their Medicare cards, blacked out their Social Security numbers, left the original in a file at home, and then carried only that blacked out card with them in their wallet, just for fear of fraud that might occur if someone could see your Social Security number. So there have been years and years of concern about this, and finally MACRA said enough. CMS, we're giving you 4 years to change this. This is a major identity theft problem. It is a privacy problem in terms of health information. It's a privacy problem in terms of financial information. So we are now going to turn the Social Security-based health insurance claim numbers that have been used for so many years into Medicare beneficiary identifiers. So we're going from HICNs to MBIs. This is a massive logistical undertaking. We are going to replace 150 million Medicare cards. That is 60 million for living beneficiaries and 90 million for deceased beneficiaries. In reading a couple of articles about this over the last few weeks, I came across one great sentence, which I wanted to quote for you all here. Someone wrote, "It's an administrative task for the ages." So the outreach that CMS is doing to try to counter some of the fear of this chaos is significant. They have a fairly large campaign going. I noticed today, if you go to their website, they have all these widgets that you can download. Coming in 2018, are you ready? They clearly want these posted everywhere. They have a website dedicated to this. They have a large section in the 2018 Medicare and You handbook about this. They're setting up call centers for both patients and doctors to be able to reach them and ask questions. So what's actually going to happen? You can take a look on the slide. That's what the new card is going to look like. We're going to move from the Social Security number to an 11-character letters and numbers. It'll be unique. It's randomly generated. Those dashes, I think, will not actually appear. And this will also require an enormous change, needless to say, in the systems that read these numbers. So CMS estimates that there are about 75 legacy information systems, both at CMS and at its contractors, that will need to be replaced in order to read the new numbers. They estimate that there are maybe hundreds of thousands of private systems, probably including many of those at the institutions where you all are, that will need to be updated. And there are also some new concerns that arise from this. There's some concern, you can read a lot about this these days, that the change itself may be an opportunity for scammers and fraud to occur. You can imagine a situation, I have a 94-year-old grandmother, someone could call her up and say, "Hi, I'm calling from CMS. I just want to make sure you got your new card," and asking to read all the numbers. There's a lot of concern that that may happen, and CMS is working actively to educate consumers that they would never call and ask for that information. There's also a concern that Medicare may not have the right address for everyone. How do you get a card to a person whose address is inaccurate, whose address is old, whose address you just don't have? Maybe there's an error on it. CMS is actively trying to partner with providers so that providers are being more active in these months before the change to make sure all the information they have is accurate. And Medicare is actually right now trying to assemble a plan for the best way to mail out the cards. Next slide. So let's review the timeline real quickly of what's going to happen here. 2017 Everybody needs to be preparing their systems to send and receive the new MBIs. April 1st, 2018, this is really quite soon, less than 6 months away. All the systems need to be ready to send and receive the new MBIs, and that's when CMS is going to begin sending new cards. That will begin a transition period. That transition period will last a year and a half, all the way to the end of 2019, December 31st, 2019. You can use either the new MBI or the old HICN. Then we move to June 2018. Providers will be able to look up MBIs through a secure web interface. And January 1st, 2020, the goal is that the transition will be complete with some exceptions. The exceptions are a little bit in the weeds to talk about here, but we can certainly talk about them in the question and answer. CMS is actively saying already they're going to be tracking readiness to make sure that everyone is ready for the change January 1st, 2020. These things are often pushed back, certainly, to make sure that everything is safe and secure and we reduce as much chaos as possible. But the goal right now certainly is January 1st, 2020. Next slide. Let's talk a bit about the scope of this change. So every year, about 20 to 30% of Americans change coverage. So that's something like 60 to 90 million Americans. What we talk about here is another 60 million in addition to the usual change. Now, there must be some overlap in those numbers, right? Some of those Medicare beneficiaries are probably on private Medicare Advantage plans, and they might be within that number of everyone changing every year, but you could largely be doubling it. So let's compare that to other things that have happened. In 2006, Congress rolled out the Part D program, which gave seniors access to drug coverage. 23 million seniors during that time changed or obtained new drug coverage. In 2014, the rollout of the Affordable Care Act, in the first year, 17 million people enrolled in the individual market or in Medicaid. And we remember, probably many of us remember, there were some significant challenges with the website. These things are natural when you have, this much change, and yet here we're talking about 60 million people being affected. When we think about those other changes, it really gives us a good sense of scale. You can imagine this is going to be a moment of significant potential chaos. And what can happen in a moment of significant potential chaos, but you have an opportunity for patient misidentification at the point of care. When you change the personally identifying information of 60 million patients in a span of 21 months, there's simply a greater risk of patient identification errors. Without the Medicare card complication, patients are misidentified in medical record searches as much as 7 to 10% of the time. The Joint Commission has chosen patient identification as one of its national patient safety goals since 2003. It is now one of its top patient safety goals. We can move on to the next slide. And why? Why is patient misidentification such a big deal? We've got two publications that we've listed here that talk about it in great detail. There are many more, but here they talk about patient identification in one survey as the #2 largest patient safety concern for hospitals in 2016. A certain percentage of patients who are misidentified will suffer an adverse event. Registration errors are actually the #1 cause of misidentification, and obviously that's what we're talking about here with new Medicare cards. 86% of clinicians report that they've witnessed a medical error from misidentification, and 31% of denied claims result from misidentification. We can go to the next slide. How does that happen? So let's take 3 circumstances. This is not the total list of things that could happen. This is not a list of things that necessarily will happen. These are very reasonable possibilities of things that happen. So I walk up to my doctor's office, I walk up to the registrar, and I give them my new Medicare card, and they look up the number. Maybe the training hasn't been great. They look up the number that I hand on my card, and they don't find the record. So they just create a new record. And it's incomplete, obviously. It doesn't have the rest of my data in it. This presents obvious patient health and safety risks. I go into the doctor's office and they don't know about my drug interactions, my allergies, my other health issues. And there's a financial cost here to the provider as well. These generally cost about $1,000 per claim to fix. What else could happen? I hand my new Medicare card to the registrar, and there's just a data entry error for the new MBI. Common, could happen. But there's going to cause a claims processing disruption. Those generally much less expensive, but they can add up about $25 per claim to reprocess. Then let's say I hand my new Medicare card to the registrar and they simply choose the wrong record and they use it throughout the encounter. I don't need to say, certainly there are patient health and safety risks in that circumstance. That's called an overlaid record. It costs about $5,000 per record to fix. Undoubtedly, the wrong insurance will be billed, and it's about $25 per claim to reprocess. So next slide. I'm going to hand this off to Christy in a minute. Just a quick recap of this section of the presentation. So beginning April 1st, 2018, we've got 60 million Medicare beneficiaries with a change to their insurance ID. That has a natural increased risk of patient misidentification, which unfortunately can have an increased risk of medical errors, which certainly can create a risk of duplicate and overlaid records, and an increased risk of revenue loss and data scrubbing costs. And now I'll turn it over to Christy to talk a little bit more about patient identification.
Thank you, Jordana. I appreciate it. And thank you all for staying with us and being such an engaged audience. Keep the questions coming in through the Q&A panel, and we will address those at the end. So if we want to move to the next slide, that would be fabulous. And what I wanted to talk about now is how you can create a one-to-one link between the patient and their correct medical records through positive patient identification. You're hearing a lot about the risks and the impact of patient misidentification. And what has been staggering is how often that happens. So if you go to the next slide, there's a number of, Jordana cited a number of different research reports that have been done on this subject. When you step back and take a look at the very highest level, 1 in 10 patients are misidentified when their medical record is accessed. So if you're sitting in a conference room and looking around, that number is very personal and quite concerning for a number of different reasons. Not the least of which is if you are misidentified at registration, and you're one of those 1 in 10, then 9% of those that are misidentified result in an adverse event, so doing harm to a patient. So the ECRI Institute researched the 9% of misidentifications that result in an adverse event. So when you step back and look at that, we are causing harm to almost 1 in 1,000 patients due to misidentification. And so that, for anybody's terms, is not at all acceptable. And that's not the only impact. The patient safety aspect is the one that is the most personal. But in addition, we are all, in the healthcare space, and this has a significant impact on us from a financial perspective as well, and we are wasting money that we could otherwise recapture. And if you go to the next slide, Jordana, I think you wanted to elaborate on some of the revenue cycle considerations as well.
So on the first slide on the left side.
Sure.
Revenue cycle considerations can be significant in this, mostly for a lot of the issues that I talked about before. We can talk about billing errors, insurance information, billing address. These are all issues that potentially are going to be changed or confused when you start to have a new card, potentially people putting in a new record. I would hope not a HIPAA breach, but potentially that could happen if you start looking at the wrong record. And certainly inaccurate billing processes create payment confusion and a huge impact on customer satisfaction.
Absolutely. So, if you think about it, as I was talking about, the 9% of those that are misidentified suffer some sort of adverse event that's harm that's actually caused. But then the financial implications, like you talked about, you think about the patient identification as the front door to patient care. And if we get you wrong, if we identify you incorrectly right up front, there are a series and host of downstream ramifications that cost our health system a lot of money. So 11%, there's 11% impact on bad debt. So if you think about, we're going to go through an example that talks about duplicates and overlays. You see this in the middle. So for those of you that are familiar with, so I'm going to give you a personal example. Before I got married, right, I was Christy Clark. Then I got married, and I was now Christy Murfitt. And now I have 2 medical records out there. Well, people mess up my new name all the time. And so if is there a Christy Murphy, they could easily pull up that record for me. Or, it's more common, Christy Clark was a very common name, and there were multiple Christy Clarks. And if you're showing up at registration and the registrar sitting in front of you has multiple potential records to pull from, what often happens? They actually often create a new medical record, which has none of my medical history. And so now I have what's called duplicate medical records. Now I might have 2 under Christy Clark and 1 under Christy Murfitt, and none of those are fully correlated to me. Now, all of that leads to a host of downstream effects that cost us money and also provide to lower quality care because my care provider isn't getting full insight as to who I am and my medical history. Now, inaccurate billing, you think about if you're using my maiden name and you don't have all of my information, you can have payment confusion, and obviously that's going to, if something comes back to me, it's not getting paid and I have to deal with my insurance company all over again. There's a lot of frustration for the patient in addition to cost to the providers. Now, moving on to cost, you can see this concept of the duplicate medical records. And there are entire organizations, and some of you are probably running those organizations, that are responsible for cleaning up the duplicate medical records in the system so that this doesn't happen. But that's just wasted money. You are, in addition to hiring folks to do that cleanup, you may be prescribing duplicate tests that have already been done and are on my other medical record. And that can mean you won't get reimbursed for that test. You will definitely cause delays in your billing and accounts receivables. And there is a host of bad debt write-off, and 20% of those are related to duplicate medical records. Now, on the far right, yes, there's a huge financial impact, but there's something called a medical record overlay. So this is if my medical record is commingled with someone else's. So they identify me improperly, perhaps they pulled the wrong record for Christy, and they started processing me on somebody else's medical record. Now our private health information is commingled, and there are lots of risks of clinical errors. Perhaps my blood type is different than the one that's in that medical record. The cost of one identifying that issue and then cleaning it up is significant. It could lead to real patient harm, and it oftentimes leads to litigation as well. So we don't necessarily want to cause all of those concerns throughout our health system, and so we do have a solution to solving that right up front. So if we move to the next slide, we can talk about how to introduce positive patient identification at registration. And you can feel free to build out this slide. It looks like the build is not fully taken. So one thing that we all have identifying characteristics. When those of you that are familiar with two-factor authentication, something you know, something you have, something you are. You need to find two pieces of those three items. Now, biometric identification, something you are, whether that is your iris scan or your palm vein scan, those are unique characteristics to you. And by identifying you through a biometric, that will ensure that regardless of any additional identifying characteristics I may have, whether my phone number, address changed, whether I come in to the hospital and am unconscious and can't actually give you any identifying information, you can use my biometric to create that one-to-one link to my medical record personally. What that does is that securely and accurately identifies your patients at any point of care. And the way Imprivata approaches this solution is that we integrate that directly into the workflow of your registrars at that registration screen, so that this isn't extra steps for them in the process. This is incorporating a biometric identification into the natural identification process that you have today. By capturing that biometric, then you retrieve that correct record from your appropriate clinical systems, and that solution is then embedded into your hospital's information systems workflow. So I'm going to dive a little bit deeper in that, but I'm going to answer the question probably on your mind. I'm seeing a couple of comments come in. So if you go to the next slide. So why biometric identification? So I alluded to that, but this is, biometrics is highly accurate, it's unique to you, and it's stable. So if you think about, I will take palm vein recognition biometrics as an example, as it is a highly adopted solution within healthcare systems. It uses not a picture of your palm, but vascular recognition. So your vein pattern that's underneath your skin is set at birth, and it doesn't change over the course of your lifetime. So if you think about using a biometric solution like that, or an iris scan as you're walking up, perhaps you're getting your picture taken for the EMR, and you can actually get a biometric scan at that same time. You see 1 out of 1.25 million folks have issue with that biometric. That is the false acceptance rate is 0.00008%. So it is a highly, highly accurate experience. And then going back to the two-factor authentication that I talked about, if you add something you are, like your biometric, and then something you know, like your date of birth, that takes your false acceptance rate down into the billions. So there's the accuracy component that really makes my personal association with my medical record stable and unique. And then usability. So can you use the technology? So this is something, technology for technology's sake doesn't get anybody very far. This has to be something that is usable and easy to adopt. So virtually 100% of the patient population could to utilize this technology. There are a few instances, obviously, if you have an issue with your hand or your eyes, that particular biometric scan wouldn't be possible, and you would go back to the original way that you would identify somebody. But for the other many patients coming into your system and presenting, this is highly usable. And it's been proven. We have hundreds of customers that are utilizing this technology in conjunction with their ADT systems and within their other points of care because it's easy to use and non-intrusive. And in addition, patients, when they hear why you're scanning their biometric, the fact that you're attaching, you're ensuring the safety and accuracy of their medical record is very well received. And in addition, they appreciate not having to give other identifying characteristics out loud, such as their social security number. So if we move to the next slide, I can walk you through a workflow without biometric identification, because I want to point out a couple areas of vulnerability. So if you walk with me, starting from the left of the slide, when a patient presents at the hospital, they come in and they visit registration, and the registrar on the other side of the table attempts to identify the patient. Now, there's a whole host of reasons why 1 in 10 of patients at the point of registration are misidentified. If you think about why people are going to see a doctor, they are often sick, they might be elderly, they might not speak the same language as the registrar, and so there were a lot of language barriers, cultural barriers, as well as physical barriers to clear and concise communication. There is also an issue that we are facing in this country with insurance fraud, and people share their insurance cards, and so they're actually attempting to get care under somebody else's plan. So those are all the issues that may happen as that registrar is attempting to identify the patient. And then they go and they find the name, they find 4 potential matches, and they might not be able to identify which medical record is mine at that point. And often a new record is created. So that's what I was referring to, the duplicate medical record. So now I not only have 1 medical record in the system, I have a net new one. So now that patient is treated, and that full panel of tests is administered, and then the patient is discharged. And after discharge, the HIM department reviews that medical record, and behind the scenes is deduplicating and scrubbing overlay medical records as a point of their course of their job. Now the claim is submitted to the insurance provider, and it's denied, because in this particular example, that patient had some of those tests already done. It just wasn't visible on that brand new medical record that was created. So the hospital does not get payment for those services, and the bad debt is written off. Now, and that happens to 1 in 10 patients. Now, if you move to the next slide, with biometrics, you eliminate a host of these steps. The patient presents to the hospital, they visit registration, and the patient authenticates via biometric identification. So there's no additional conversation. You're breaking through the language barriers you might have. You are stopping active insurance fraud, should that be happening. And if somebody is, if you think about somebody that might have Alzheimer's or dementia, or might be presenting unconscious, they wouldn't be able to tell you much about who they were, but you could still place their hand on a biometric scanner and identify who they are. So then that patient is positively identified, treated, and discharged. And that biometric identification, as I said before, creates a one-to-one link between that patient and their medical record. And this all improves, first and foremost, patient safety, but then it eliminates your issues of duplicates and overlays and preventing that insurance fraud. Now, let me move to the next slide and just talk about data integrity as a foundation here, because what you're seeing is there's a lot of spot for human error, but there's also, as we've moved to the electronic medical record system, now we have to pay attention to the quality and integrity of our data. And so that is the foundation of digital healthcare. You must ensure that when you adopt a new system, so if you're moving to a new EMR, for example, there's a large amount of data conversions that need to happen. There's a large amount of integrations that need to happen. There are different medical record numbers for patients across different facilities that need to be rationalized and brought together. Data needs to be standardized, and there's a host of incomplete data. So this is why there's such an investment in data quality cleanup, but really ensuring every organization has a different approach to maintaining the quality of their data, whether it's through their own HIM staff as a part of an everyday job, whether it's through outsourcing that cleanup prior to any major migration from their systems. But it's a known issue that in a digital healthcare environment, you need to ensure that the foundation of what you're working on is clean. So if you go to the next slide, there are a series of best practices to consider for positive patient identification and patient matching. So obviously this is about people and process as well as technology. So you need enterprise-wide governance policies and procedures to set up your foundation. And a whole series of them are listed here. You need an approach to centralize your enterprise master patient index for data integrity. You obviously need training. How do you make sure that the registrars are doing the right things and utilizing the tools and systems that you provide accurately and effectively and consistently? And then when you overlay a solution with a biometric component, that eliminates many of the areas of human error that dramatically streamline your the financial integrity of your systems, really ensure that you're getting the most out of the investments that you've made, and not adding additional levels of, let's say, for lack of a better word, dirty data into your systems, and really preserving patient safety, which is really what our healthcare system is aligned to do. So in summary, we can jump ahead. I really appreciate Jordana being on this call and taking us to a broader perspective of the issues that are on the table today and how significant an issue patient misidentification actually is, and how relatively straightforward it is to stop some of the areas of human error with a simple technology. But the reason that we're talking to you today is because there is a potential when this new Medicare card initiative takes effect in April that we are likely going to see an increase in that patient misidentification rate, which is already far too high. So by looking at how to ensure you are accurately identifying those patients and their information, that's going to help you avoid a host of clinical errors, a host of overlaid and duplicate records, a host of areas for potential revenue loss. And so this is your time to proactively ensure that those 60 million Medicare beneficiaries receiving a new Medicare card, you have a solution that will ease that transition, because those 60 million folks, next time they come to get care at your organization, that identification process is going to be far more complex, which is going to mean that 1 in 10 errors that we typically see is likely to go up. So final slide, and then we can look at some of your questions, is you can solve this problem today. There are a couple of ways to look at it, but if you think about the cleanup that we talked about, the EMPI solutions, the biometrics, Imprivata approaches positive patient identification through a combination of biometrics and medical record cleanup. So being both proactive and reactive. So reactive means you need to clean up the data that you're starting with, reduce those duplicates and overlays, and then every patient moving forward, make sure that they are matched from a one-to-one basis to their medical records on a biometric level, which just accentuates, complements the solutions that you have and shores up some of those gaps that exist in the solutions today. Okay, so with that, I think we have some questions, and let's start taking a look at those.
Thank you so much, Jordana and Christy. That was a very informative presentation. So we will now kick off the question and answer session. Just as a quick reminder to our audience, you can submit any questions you have through the control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as time allows, but our presenters will follow up with any that go unanswered via email. So with that, let's get started. Our first question from the audience is, why is it necessary to generate Medicare numbers for 90 million deceased patients unless recently deceased? And is there a need to settle their Medicare accounts?
This is a great question. It's actually one of the most common questions that we've received in talking about this issue. I think people are just fascinated by the breadth of this number and why do we have to do this. I think there's probably a couple of reasons. One is just claims run out, which is sort of your question kind of alludes to. Bills obviously come in for quite a long time after a procedure or any significant interaction with the healthcare system occurs. I'm sure many of you have experienced that, either after any kind of event for yourself or after the death of a parent or grandparent. There's a second reason, and to some extent I'm surmising here, but Medicare records are used for research purposes, and as Christy sort of talked to you about the need for kind of clean data, my guess is that there's a strong desire for the Medicare data set to have some integrity to it in terms of being able to pull those records with a consistent paradigm, and so they would simply like to re-identify the records of deceased beneficiaries as well.
Thank you. Perfect. So our next question refers to a stat you mentioned earlier. I believe that overlaid records cost $5,000 to fix. So we have an audience member who wants to know why those cost so much to fix.
Yeah, sure. Oh, Chrissy, go ahead.
Yeah, we can, as a part of the presentation, there are sources on that data, so I'm more than happy to send you that source. But if you think through, and Jordana, feel free to elaborate on anything you want to add. So if you think about an overlaid medical record, you're commingling two different people's medical data. The first issue you encounter is that I could no longer access that medical record because it contains private health information that belongs to someone else. So now you have two people who do not have access to their own medical record. So you've got an issue there that you have to get legal counsel involved. You also have to get typically a more senior person of your HIM staff that gets involved to tease out the specific differences, look back at the specific dates of service, and make sure that you actually talk to the clinicians and tease out whose information belongs in which record. So there are legal implications, there's clinical involvement, you get revenue cycle and billing throughout the chain, and you have many more people involved to decouple that information and create two distinct medical records. Jordana, is there anything that I missed?
No, that's perfect. The only thing I would add, and certainly you can have access to all this data, in terms of the stat on $1,000 per record, that's from an AHIMA task force. I'm sure that's an organization many of you guys are familiar with, but you can also access all of this after the webinar as well.
Thanks, Jordana. So we have a couple questions coming in about the risk of Medicare beneficiary identifiers versus the risk of social security numbers. So we have an audience member who wants to know if a patient's current Medicare ID number and their new MBI will have to be linked in some manner to correctly identify the patient, what would prevent this connection from becoming a path to hack and exposing the patient's data?
I'm not an expert in this area. I can answer the sort of general question of sort of why MBIs versus social security numbers. A social security number is not just specific to a health record as it is in its use in the Medicare program. It is specific, as you know, it's quite obvious probably, to so many other sensitive pieces of information that we use. We use our social security numbers to apply for our mortgages, for bank loans, for credit cards, for so many other places in our lives that we would not want to have fraudulent access available to. And so it's simply safer to have an MBI, which is specific only to your Medicare record and not to all these other sensitive areas of our lives. In terms of the hacking question, I'm not sort of an expert on those pathways. I don't know if Christy can answer. If not, we can certainly get you an answer after the webinar.
Yeah, I think that's something I would like to follow up with the folks who asked about it, because I want to dive into where that's coming from in terms of hacking. So you can't fake a biometric because it's part of who you are, so only that person can utilize it. When you talk about hacking the system, the biometric itself is encrypted and not usable. It's not, a picture of a hand can't be faked. So it is encrypted, but I think there's a lot more technical detail that you probably want to get into on the security side that we're happy to follow up on.
Thank you both. That's very helpful. Our next question about the MBI is about how current data indicates approximately 10% of patients are misidentified. If you add on another layer to the identification system with this MBI, does that complicate the situation more? And will it magnify inaccurate information, multiple medical records, misidentification issues, and the like?
I can take that one. So positive patient identification through biometrics has been deployed successfully at hundreds of health systems in the U.S. And what they have seen is that adding the biometric actually decreases a number of the time it takes to register a patient. When they come back, all they do is put their hand down or scan their iris, and they tell their date of birth for their second factor, and that streamlines that experience for the patient, and it minimizes the number of inputs that the registrar themselves are collecting and retyping manually. So it actually is something that we have found that streamlines a number of processes and eliminates those opportunities for human error. I hope that answered that question sufficiently.
Yep, that was perfect. Thank you. We have an audience member who'd actually like to know a little bit more about the different biometrics suggested. I know you mentioned iris. Can you do facial biometrics, voice, et cetera, Christy?
Sure. So let's talk about the two biometrics that are actively in use in health systems today for identifying patients. The first one that started to be utilized in the last 10 years is palm vein biometrics. We talked a little bit about that. It sounds definitely like science fiction, all of it. But this is something that the reason for palm vein versus a fingerprint biometrics, we get asked that question a lot. If you think about this, the general public associates fingerprints with law enforcement, and there's generally a pushback and concern about using your fingerprints to identify yourself anywhere except if you're getting fingerprinted in downtown somewhere. So the palm vein is something that's very simple. You set your hand down, and I've been in health systems that have this solution. I've watched patients walk up and, as a part of the conversation, rather than shaking somebody's hand, they just slide their hand in to get their scan, and it works really conveniently. The iris scan is often utilized for organizations that are installing cameras into their registration system and incorporating photos into their EMRs. Many folks out there have initiatives to add patient photos into the EMR, and so this gives you an opportunity to really streamline that workflow and get a 2-for-1 photo as well as a biometric scan in one experience. There's been a lot of discussion about facial recognition in the past couple of weeks with a lot of the social media giants focusing on facial recognition. We actually have some materials that talk about the accuracy and appropriateness of various biometrics and where they are in the stage regarding the one-to-one accuracy and mapping versus the one-to-many. Now, in an area like for social media, if the false acceptance rate of a facial recognition match is high, that's okay. If I'm tagging my mother in a picture on Facebook versus me, that's, doesn't do much harm. But if the false acceptance rate is high in a clinical environment, that's unacceptable. You'd much rather have a false rejection rate. So I want something that's much more accurate, and I want to tune that system. I'd rather have them reject you and have you place your hand down one more time for a second scan if the first one didn't take, rather than just take everything that comes along. So there are a lot of different biometrics. Imprivata itself uses biometrics in a variety of different workflows for our clinicians that access systems. Many of them use their fingerprints. It's a smaller pool. They're employees of the health organization, and it's much easier enforcement. But when you're talking about engaging a general population, there's a number of different things you need to consider, from acceptance rates to accuracy. So that's definitely a conversation we'd be happy to engage in to help identify which biometric technology might work best in your workflows.
Thanks, Christy. That was very helpful. So how many providers are currently using biometric identification with Imprivata industry-wide?
Sure. So there's 65 health systems and that utilize our solution, and that represents hundreds of facilities that utilize the solution. This concentration is in the U.S., although we are seeing expansion in Australia and other areas of Europe.
Perfect, thank you. And we have time for just about one or two more questions. Do you see CMS requiring biometrics at some point?
That's a good question. So interestingly, in the fiscal year 2018 Labor, Health, and Human Services funding bill that came out of the House Appropriations Committee, there actually was a request that directed the Department of Health and Human Services, and by that they mean CMS, to issue a report on the estimated impact if hospitals were required to use not biometric identification, but patient matching technology. So a report, of course, is not legislation, but it speaks to sort of a future in which Congress could take up the issue of patient identification in a far more serious way.
Makes a lot of sense. Well, it looks like we are all out of time, but I would like to thank Jordana and Christy for their excellent presentation, and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.